So our goal ultimately is to try and improve the outcomes of children that are born with congenital cardiac anomalies by making materials from their own cells. So our grafts are highly resistant to calcification, which is has great implications with pertaining to their durability. And we shared all this information with the FDA, and they gave us something called breakthrough designation, which means that based on the data that they feel that our product has a substantial ability to be better than anything else that's available. We discovered that we did the right thing for the wrong reason. We had always thought that the bone marrow cells were a rich source of stem cells that could transform into the endothelial cells and smooth muscle cells that normally make up a blood vessel.
Welcome to the next episode of Exploring Prosperity, where we're stepping into the cutting-edge world of regenerative medicine with Dr. Chris Breuer, one of the world's most accomplished surgeon scientists. Dr. Breuer's team has been producing technological breakthroughs over the past 30 years towards helping newborn babies survive, grow, and ultimately thrive after they're born with critical congenital heart defects. His dreams were formed early in his career where, as a specialized pediatric surgeon, he faced the challenging task of treating many of the country's 3 in every 1,000 babies born with severe heart defects. Often witnessing heartbreaking outcomes despite his best efforts, Dr. Breuer embarked on a relentless pursuit to overcome these challenges, driving his determination to innovate and save lives. His focus has propelled him to become one of the world's leading authorities in the emerging field of regenerative medicine. Today we're going to explore the journey of Dr. Breuer, who's valued around the world as a true medical visionary. We'll hear about his early days, the evolution of the regulatory environment, and how impactful his research is promising to become. Dr. Chris Breuer, thank you so much for joining me. It's an honor to have you on the show. I would love for you to share with us your specialty in tissue engineering and where your work has taken you to today.
Okay. Well, Bob, first, thank you very much for this invitation. It's a pleasure to be here with you. So my name is Chris Breuer, and I'm a surgeon scientist. And for the past 30 years or so, I've worked in a field that's called now regenerative medicine. Historically, it was called tissue engineering. So within biology, tissue can be defined as a group of cells working together to perform a function. So, for example, we have skin cells that keep our body separated from the outer world, or blood vessel cells, which help blood flow without clotting. And tissue engineering is a science that tries to take an interdisciplinary approach in order to create tissues from its cellular components using a variety of engineering methods or techniques. And the method that I've been trained in uses a device that's called a scaffold, or a three-dimensional matrix, which can create space for cell seeding and tissue formation, and can be used to serve as a template to direct the tissue formation, so that at the end you can create a tissue. And the impetus for this work is as a surgeon on a daily basis, we're constantly removing tissues that are either diseased, damaged, or congenitally absent. And frequently you don't have sufficient tissue in order to reconstruct a patient after doing an operation. So in those situations, surgeons are forced to use artificial man-made tissues or transplant tissues from one individual to another. And both of those methods are fraught with complications. So the ability to be able to create tissues that are made from your own cells could really augment what a surgeon's capable of. And as I mentioned, for the past 3 decades, we've been working in the field of cardiovascular tissue engineering. And our goal has been to make better materials for use in the surgical treatment of children that are born with congenital cardiac anomalies. So taken together, congenital cardiac anomalies represent the most common birth defect. And despite significant advances over the last half century in the treatment of these patients, it remains a leading cause of death in the newborn period. And one of the main sources of complications are, again, the fact that surgeons are forced to use these man-made materials in order to do these big reconstructive operations. So our goal ultimately is to try and improve the outcomes of children that are born with congenital cardiac anomalies by making materials from their own cells.
This show is being brought to you by our sponsor, Truflation. Professional investors and economists, and probably any casual observers, Know that government inflation statistics are only an approximation of what real inflation is. Not only that, but the government has a conflict of interest because high inflation can be so damaging to the economy, the deficit, and our $34 trillion in debt. Trueflation collects over 13 million pricing data points. Most are updated daily to reveal inflation with precision for asset managers, governments, companies, and the general public. Check them out at trueflation.com. What was the condition of this industry when you started in it, and how did your path take you here?
Yeah. So the term tissue engineering wasn't even coined until the very late 1980s, almost 1990s. And I was fortunate to work in one of the very first tissue engineering labs in the world. It was a laboratory in Boston that was a combined laboratory with MIT and Harvard. And I worked under the direction of a material scientist named Bob Langer and a surgeon scientist named Jay Vacanti. And both were early pioneers, and many consider the fathers of tissue engineering. So it was at a very nascent stage when we started. The lab was interesting. When you would come into a tissue engineering lab, there might be somebody working on bone in one corner of the lab and another person working on intestine in another corner, and maybe somebody working on a blood vessel in the third corner. So it was sort of like a short attention span theater where all kinds of crazy things were going on.
So what was the old technology, and how is it evolved into the new technology? Just granularly, what happens with the patient back then and what happens with the patient today?
Yeah, so congenital heart surgery is a very dynamic field, and there have been extraordinary advances, over the past half century. But again, the one area that we're focusing on is the fact that many of these reconstructive operations need the use of materials in the form of either vascular grafts, vascular patches, or replacement heart valves. And whenever these aren't made from an individual's own cells or tissues, they result in complications. So we're still working on designing the first tissue engineered products to be used. So again, the translation of these technologies from the bench to the clinic is still in the field of evolution. We hope that we can continue to advance the field.
You are conducting human trials now, and so it's working to a great effect, I assume. And in the old days, it was a scaffold that could not move, could not grow, and so there were repeated operations needed over years of children being treated with the old vascular grafts.
That's right. So our research team was the first to use tissue engineering in the clinic. I've worked with another surgeon scientist by the name of Toshi Shinoka over all this time, and he was actually the first surgeon to use this technology in a human and perform the first clinical trials. And then together we performed the first FDA-approved clinical trial and are currently in the midst of the second FDA trial evaluating the use of tissue-engineered vascular grafts in congenital heart surgery. Now, these are still in an investigation, and so I certainly don't want to overpromise on a technology that we're still studying. But one of the interesting discoveries that we've had both in our animal work and also in the humans is that when you create a vascular graft out of an individual's own cells, it possesses growth capacity. And one of the fundamental problems that a congenital heart surgeon faces is what's called somatic overgrowth, which is a fancy way of saying that a child can outgrow their operation, just like they can outgrow their clothes. Unfortunately, it requires another operation if you outgrow it, and that increases the potential complications. Redo surgeries are more complex. They have a higher rate of adverse events. And therefore, the ability to create something that can grow with a child has great potential for improving outcomes.
Yeah, well, you have the adverse event risk of a single surgery in this dangerous area of the body rather than multiple surgeries. The promise or the potential for this technology is to operate at very young ages, isn't it?
That's right. Many congenital heart operations are performed a little later in life than they need to be. And that's because surgeons have developed strategies to try and reduce the number of redo operations. The ability to operate earlier could, in some circumstances, provide an important improvement. For example, some of the heart diseases that we've developed tissue engineered products for are for the treatment of what are called blue baby syndrome. In blue baby syndrome, children have mixing of their oxygenated and deoxygenated blood within the heart because of these structural anomalies. And this causes what's called cyanosis. And cyanosis is a reflection of the fact that the oxygen content is lower than it should be. And hypoxia or low oxygen levels is bad for growth and development. Furthermore, because of some of these structural anomalies, there's increased flow of blood through the heart because the heart is pumping in parallel instead of series. And this creates volume overload, which over long term can cause heart failure. So by delaying surgery, to try and prevent having to reoperate, the cost is that these children are being exposed to longer periods of low oxygen levels and volume overload, which can have significant deleterious effects on their growth and development.
Going back to the beginning, what were some of the fun experiments that you were doing to prove that things would work in tissue engineering or not work in tissue engineering?
Yeah. So when I was in the laboratory, in the Vicanti laboratory, there was a experiment that was performed by another researcher in the lab, a doctor by the name of Ethan Chow, that really caught the eye of the country and became sort of a phenomenon. It became known as the auriculosaurus. And what Dr. Chow was a plastic surgeon. And one of the operations that's sort of the measure of the man when it comes to plastic surgery are operations for what are called microtia, or abnormal ear development. And when you're born with an abnormal ear, it's a very noticeable birth defect, and there's problems associated with that. So when a surgeon historically would reconstruct an ear, what they would do is cobble together pieces of cartilage from all over the body. So they would take little pieces of cartilage from your rib, from different parts of the body, and then on the operating room table, put it together in such a way that it looked kind of like an ear.
So hopefully it resembled.
Then they would put that under the skin. And, sometimes the results were okay, sometimes they weren't okay. It kind of depended on how much cartilage I could cobble together. So this
Was it
experiment
more art or science?
was much more arts and crafts than science. But so what Dr. Chow did was actually a very beautiful proof of principle experiment. He determined that you could grow cartilage cells in culture and you could expand their number greatly. So you could take a tiny, tiny biopsy and turn it into millions and millions of cells. And then he could put those cells on a scaffold or a matrix that he could make in any shape they wanted, and the cartilage would grow to that shape. So what he did in this experiment is he made a scaffold in the shape of a human ear. He filled it with chondrocytes. He grew the scaffolds and the chondrocytes together in an outside of the body and created a cartilage in the shape of a human ear. And then he would implant it in a mouse. And so we had these mice running around the laboratory with giant human ears. And so that looked pretty weird from the outside looking in. But from the inside looking out, you realize it was just a demonstration of the potential of tissue engineering, that with this new technology, we could really expand our capabilities.
I remember that picture made the rounds on the magazine, on some of the magazines at the time.
Yeah.
Quite
Yeah.
amusing.
The lab had the dubious distinction of having publications in the National Enquirer and Science in the same year. Science is the big scientific journal that everybody wants to publish in.
What were some of the hypotheses you had about how all of this science would unfold? And what were some of the things, the early big things that you learned that shifted your track and made you learn things that you didn't know before? There
Sure.
must have been a mountain load of those.
Yeah, there really are, and I'm very good at failing, and that seems to be a recurrent theme. So first, just a little bit of history. So while in the laboratory, Toshi Shinoka and I were the first to do cardiovascular tissue engineering in the lab, and we created the first tissue engineered heart valve and got it up and running in a large animal model, and then we created one of the first tissue engineered vascular grafts or blood vessels, and the first really designed for use in kids in order to take advantage of its growth capacity. And upon completing our time in the laboratory, I returned to finish my surgical training while Toshi returned to Tokyo Women's Hospital, his home institution in Japan, and he started his own laboratory. And when he got to the point that he was very comfortable that the technology worked, he actually did the first in human study in planting a tissue-engineered vascular graft in a young child who needed a pulmonary artery reconstruction. So Toshi returned to Japan and did the first translational work. And it's really, his publication in New England Journal of Medicine is really considered a seminal publication. While Toshi was doing the translational work, I was completing my surgical training and then started my own laboratory at Yale University, where we were quite interested in studying the cellular and molecular mechanisms of how these tissue engineered vascular grafts work, and had a number of interesting discoveries. The first discovery we had was that we were doing the right thing for the wrong reason. We made our grafts by taking cells from an individual and putting them on the scaffold. So in the beginning, if we wanted to make a blood vessel, we would take a biopsy of a blood vessel, expand the cells in culture, seed them onto our scaffold, and then implant it in our patient or in our animal. But we discovered over time that sick people had sick cells. So we began to look for alternative cell sources and discovered that you could use bone marrow cells or different fractions from the bone marrow cell to do the same thing. But the bone marrow cells had the unique advantage that they were available in such abundance that from a single bone marrow harvest, you had enough cells to make a graft without culturing the cells and expanding the cells. So now you could make a vascular graft in the same day that you needed to use it. You could harvest your bone marrow cells, seed them onto your scaffold, and implant it immediately. So this had great advantage. And it worked. It worked in large animal models, and it worked in humans in our early clinical studies. But when we actually started to study it rigorously, we discovered that we did the right thing for the wrong reason. We had always thought that the bone marrow cells were a rich source of stem cells that could transform into the endothelial cells and smooth muscle cells that normally make up a blood vessel. But what we discovered when we did rigorous cell tracking experiments using transgenic mice is that the cells that made up the blood vessel were not derived from the bone marrow, and instead grew in from the neighboring blood vessel into which the graft was implanted. So in essence, we were enabling our own blood vessels to regenerate tissue rather than creating tissue from seeding cells onto the scaffold. And it was funny because when I was doing this experiment with the students and fellows in the laboratory, they kept coming back with the data showing me that the cells were not derived from the bone marrow, and I kept making them redo the experiment because that's not the way it was supposed to work. And finally, the light went on that I was wrong and they were right, and so we were doing the right thing, but for the wrong reasons.
And they did not flunk the course?
Oh, no, they got A pluses.
That's really amazing. And there were other discoveries like that along the way?
Yeah, so that really did open a whole new way of looking at things. So then we started to ask questions. You know, why were we seeding the scaffolds? And if you just implanted a scaffold without cells, sometimes they would form beautiful vessels, but a lot of times they wouldn't. They would form scar tissue, or they would stenose, which is the most common problem that we see when we use these grafts clinically. It's the most common adverse event. And so we started to study the role of cell seeding and discovered that the cells did not contribute to the vascular neotissue, but they were very important for the neovessel formation because they reduce the incidence of stenosis. And the way it actually happened is that the tissue formation was actually controlled by our own immune systems. So we discovered that if you implanted a seeded scaffold or an unseeded scaffold into an animal and you turned off their immune system, you wouldn't form any tissue, and that's not what we wanted. But if you implanted the scaffold and they had too much inflammation, they would form the scar tissue or stenosis. So that the new tissue formation or neotissue formation was an immune-mediated phenomenon and needed to be properly regulated. And that what the cell seeding was doing was actually serving an immunomodulatory function that would enable tissue regeneration and prevent tissue scarring.
You've filed a lot of patents. How many patents came from what you expected, and how many came from what you did not expect?
Well, I think virtually all of the patents came from things that we didn't expect, and that's what made them patentable.
Oh, of course. It's so fascinating. And how many patents are there?
I think I currently have about 20 in this space.
You've been testing this in animals for how many years? And you worked very closely with the FDA throughout the whole process. How did that cooperation go? And at what point, what was necessary for them to allow you to start testing it in humans? And those trials obviously have gone well enough that you continue to be testing in humans. How did it all work, and what was the timing for all of that?
So we started doing our animal experiments over 30 years ago. When Toshi did his first implantation and reported it in humans, it was actually about 9 years after we had started the studies. But at the time, he was working in Japan, and there were no regulatory agencies involved with this. And what's interesting is, how do you bring something from the bench to the bedside? And when I started doing this work, I assumed there was just sort of a rule book, and you sort of went in and followed it. But tissue engineering was such a new science that the regulatory fields didn't really know how to deal with it at first. And because there were no sort of guidelines, we started just by taking the historical perspective. And if you look back at the field of vascular surgery or cardiovascular surgery, one of the major developments was the development of the first man-made vascular graft. And that was called the Vinian graft, which was a graft that was made in the 1950s. And before that time, you really couldn't do vascular surgery because there were no vascular grafts. You could sew a blood vessel to a blood vessel, but there weren't any sort of off-the-shelf available vascular grafts available. And in the early 1950s, a medical student by the name of Arthur Varese was working in a laboratory at Columbia Presbyterian, and he created the first man-made vascular graft. And it was made from a material that parachutes were made out of called polyvinyl chloride. And he literally, it was just an inexpensive waterproof material that he was able to purchase. And he had his wife help him with the sewing machine. They started making these tubes, and they started to implant them in dogs as vascular interposition grafts. And in 1952, he had a publication in the Annals of Surgery, which was the big surgical journal at the time, really a highly respected journal, describing his experience with 30 dogs. And it was an interesting study because some of the dogs died, some of the grafts failed, but some of the grafts worked, and so that was kind of exciting. What was really extraordinary is 2 years later, he had a second publication, and it was their experience with 17 patients. And as you'd imagine, 7 of the patients had died or had serious graft-related complications. None of the patients were followed up for that long. It was only 2 years for the study to begin. But with only doing 30 dogs, he was able to get into the clinic. And whenever you think about bringing something from the bench to the clinic, you need to realize that it's a cost-benefit analysis. And what's important to recognize, in the 1950s, they were doing this operation to treat people that had what were called abdominal aortic aneurysms, which is a dilation of the aorta. And if these aneurysms are left untreated, ultimately they rupture and the patient dies. So at the time, in the early 1950s, if you had an abdominal aortic aneurysm and developed any sort of tenderness, your 30-day mortality was just about 100%. So even though some of these grafts failed, the alternative was, certain death. And so, worked really well as a great way of doing things. Now, fast forward almost 50 years, and Dr. Shinoka's in Japan. He has developed this new, what he thinks is a game-breaking technology, and he works with it in the laboratory in a number of large animal studies. And when he gets to the point that he thinks it's okay to bring to the clinic, he goes to his hospital and goes to what's called the Institutional Review Board. And he says, I want to do, this study, and this is the data that it's based on. I think it has the potential to help patients. And they analyzed it, looked at things, and thought it was a reasonable thing to do and let him go. And fortunately, the results were great. And so it was a really good move. But I often wondered, what would have happened if things were a little bit different. And only 2 years later, there was another publication in a prestigious European journal where one of the first tissue engineered heart valves was taken to the clinic. And at this one hospital, 4 patients underwent implantation with a type of tissue engineered heart valve that was made using a slightly different technique. They would take a pig heart valve, they would remove all the cells, which removed the immunogenicity, and then they would implant that as the scaffold, and that would become repopulated with their own cells. And they had beautiful, very compelling large animal work. But in this particular study, what happened is that 3 of the patients died because the heart valves failed, and the remaining patient had the heart valve removed prophylactically. And when they analyzed the heart valves, what they discovered was that the heart valves had been incompletely decellularized. So there were still pig cells on these heart valves. So they were rejected. So it was, an obvious outcome. So when I read this paper, it really highlighted the importance of the regulatory agencies to me. So I've always been a big fan of working with the FDA and view them as a sounding board and an independent entity that can critically review my work and we can work together to try and develop these technologies.
And you and other pioneers in this field all contributed to how it should be regulated. Is that right? I mean, because it was so new.
Yeah. So what's interesting is it's a growing science, and we're kind of working together. What and it's slow. I wish I could go faster than I've gone, but I think we've been very safe and very cautious in our approach. And one of the reasons why we have to be that way is because the bar has really been raised. This isn't the 1950s. You don't have a 100% chance of dying if you have an aortic aneurysm. If a child has some of the congenital heart diseases that we're interested in fixing, there is a mortality associated with that, and there are complications associated with the current grafts, but the early mortality is fairly low, and the gains will come from more late-term follow-up. So we have to be more cautious moving forward.
Exactly. Well, and that you started off in pediatric surgery, and so you got to actually do some of these procedures, and you saw these patients coming in. Tell me about the difference in probabilities then and the probabilities now, which is what you were just touching on. But I'd be very curious. And the incidence, has it changed much? Children that are born with these problems.
So the incidence of congenital heart disease remains stable. It affects about 1% of all live births, and about a third of these are what are called critical defects, which are life-threatening. So unfortunately, it's a problem that's sort of here to stay. I think outcomes in the short term continue to improve and are quite good, but late-term complications are becoming more and more pronounced. And we're really learning about new complications because remember, many of these patients just would have died years ago. So when they're getting into adulthood, we're seeing problems. And what's interesting is I'm constantly having to recalibrate. So one of the things that I did uh, almost by chance is I started to do much longer term experiments. I started to do some of my implants into animals, and rather than sacrificing the animals and looking at the tissue under a microscope, I just started to use different imaging technologies to follow them over time and started to follow the animals longer and longer. And now we're finishing up an experiment where we're following animals over their natural lifespan. Our large animal work is done in lambs, and lambs live to be about 10 years. And currently I've got a cohort of 20 animals. 10 have grafts, tissue engineered vascular grafts, and 10 have the grafts that are currently used clinically. And the later we follow these graphs, the more interesting and important things we learn. We've had several really, really important discoveries this year alone. We've been able to confirm the growth capacity, and that was one of the big things that we were really interested in. Another thing that we discovered is that the biomechanics of our valve are actually much better than the current state of the art technology, which improves their performance. Our grafts are very compliant, and that compliance is very important for their function. And compliance match is one of the characteristics that our graft has that winds up giving the patients better exercise tolerance and better quality of life. But probably the most important discovery we had is that any material that's used in congenital heart surgery, the late term cause of failure is calcification. If I put in a heart valve or a blood vessel that's man-made, it will calcify when implanted in a child. And that hurts function, that can cause material failure, that can require reoperation. And one of the things we noticed in our lamb study was that none of the tissue-engineered vascular grafts were calcifying, while all of the standard of care grafts were. And that was very exciting, especially since we're so far into the study. So what we're able to do then is go back to some of our clinical patients and image them using CAT scans, which can detect calcium, and again confirm this in humans too. So on our grafts are highly resistant to calcification, which is great, has great implications with pertaining to their durability. And we shared all this information with the FDA, and they gave us something called breakthrough designation, which means that based on the data that they feel that our product has substantial ability to be better than anything else that's available. So that's been useful in helping us, try and continue with our clinical trial and make this more readily available.
What are the benefits of being designated breakthrough potential?
The biggest benefit by far is that it gives you much better access to the FDA. So they have a special team of people to try and help you solve problems, and that really can accelerate the whole translational process. So much better access to the FDA.
Now, ultimately, all of these discoveries combined will result in new surgical procedures, I assume, right? There's a process of operating on these patients that will be trained and I assume standardized in some fashion. How does that all work? And if it all plays out the way you would hope, so that the most amount of these children can be saved and live long and productive lives without having to go through further surgeries, how would that play out? Are there companies that are providing, prepackaged kits, and are the surgeons spending a week or a month or 2 years? And is it surgeon training surgeon, or are there faster ways to train everybody?
Yeah, so there's sort of a couple questions embedded in there. At a high level, one of the things that's interesting is how things are regulated. So a drug or a device are highly regulated by the FDA. Something like a blood product or an organ for transplantation are regulated in a completely different way, perhaps a little less rigorous. And then actual regulation of doctors and surgeons and how they are regulated is even different still. And so one of the things that's interesting is we're starting to see more and more things more and more regulated, which I think at the end of the day is a good thing. So, for example, there are methods for imaging people while they're operating, and you can actually watch their movements. And just based on their economy of motion, you can determine if somebody's expert or a neophyte. And I think we're going to see more and more regulation of all aspects of medical care, which ultimately I think will improve quality and will be a very good thing. The other question sort of embedded in there is if we were able to gain FDA approval, and we're in clinical trials, we haven't done that yet, but hopefully we'll get there someday. How do you implement a new technology? And that too varies greatly. I think the method I'm most in favor of are creating centers of excellence, where you bring the technology out to a handful of expert centers and help them do their first few cases. And it's interesting. When a congenital heart surgeon is taught to do the operation that our graft is designed for, they're all taught to put in grafts that are bigger than they're supposed to be. They're oversized grafts. It's like buying your kids bigger shoes so they don't outgrow them too fast. And when we have studied the grafts in animals, we've discovered that oversizing is actually bad for the tissue formation. You actually get a worse graft if you oversize it. It's much better to put in a size match graft. But telling a surgeon to put it in a smaller graft than they've been trained to put in takes a little bit of coaxing. And they need to see the data, and they need to be able to understand some of these things. And so really helping people and proctoring through those first few cases and rolling it out in a more controlled fashion, I think is the best way to get the best results and optimize the use of the technology. Similarly, when we place these grafts, during the first 6 months while the scaffold's degrading, initially the grafts dilate and then narrow and then open up again. And recognizes these changes and what's normal and what's abnormal. There's a learning curve to that. So I'm a big proponent of creating centers of excellence and proctoring people and rolling out the technology in a more gradual way. And I think ultimately we'll get the best results and help the most people out there.
Well, and I imagine these surgeries are so important and rare enough that it's a sort of ailment that would accommodate a central location for a period of time until you had enough surgeons. And are there any parts of the procedure that require special equipment that can't be provided to a large number of hospitals?
Yeah, so from a surgical procedure standpoint, no. But from a making the grafts standpoint, yes. So the way we make the grafts, where we have scaffolds, and the scaffolds are produced just like vascular grafts at an outside institution, and they can be stored and have a shelf life. But on the day of surgery, the patient comes in, they have their bone marrow harvested, and then that bone marrow is brought up to what's called a clean room, and a team of people take the bone marrow, isolate the cells that we seed under the graft, seed the graft, and then do a variety of tests on the graft to make sure that it's okay for implantation. And that whole process requires a lot of training and a lot of specialized equipment, and will limit the number of places that can use this technology initially. However, we've created both closed disposable systems that can be used in the operating room, and even cell-free systems in our animal work that I think ultimately will be the answer that will give you that off-the-shelf availability and make this available to everyone, and it'll be much simpler.
You have been an active surgeon for nearly your whole career until recently. Is that common among researchers working in the cutting edge of certain fields like yours, or is it unusual? And tell me about the evolution of surgery over the last 30 years. Is it easier or harder for a surgeon to become excellent?
Yeah. So I think a surgical researcher, it's hard to be a surgeon, and it's because surgery is like a sport. The more you do, the better you get. So if you're not devoting 100% of your time, then that can be detrimental to your surgical skills. So if as you get more and more into research, it's a balance. And then in my particular case, as we got into our final clinical trials, this was something that I devoted my life to and wanted to make sure that if I succeeded or failed, I wanted to give it my best effort. So for the last couple of years, I've devoted myself exclusively to the research. And I was able to make that decision because I thought the reason I made that decision, again, is that I wanted to just give it my best shot. I think within the field of surgery in general, one of the things that has really been changing is a real move towards subspecialization. So there are fewer and fewer general surgeons and more specialized and super subspecialized surgeons. And I think that's terrific from the standpoint of the technical aspects of surgery. I think if you do a limited number of procedures, but you do high volume, that you'll get better and better at it, just like anything in sports. But I think we have to be careful that we don't let the pendulum swing too far in that direction, because you still need somebody that can be a captain of the ship and can see the big picture. And so I think we need a combination of surgical subspecialists, but at a minimum with enough generalist training so that they can take care of the whole patient and they don't lose the forest and the trees.
Are there enough surgeons coming out of medical school every year?
I would say we're doing okay. It remains a popular field. Some other subspecialties are having problems. So the more general specialties, things like family practice, things like pediatrics, I think we need to train more people.
How about the overall system for developing innovators in medicine, particularly in surgical practice? It sounds like it's a very good system that you don't have any complaints about. Has it been more of a hurdle to get things right? or more of a benefit?
For surgical research, I think surgical innovation in general, I'm always amazed. I'm always amazed at the results. I think if I look at just over my career, the technical innovations that have come along have really just been amazing. Both through surgeon scientists and from industry, that advent of minimally invasive surgery, robotic surgery, just the things that we're doing today are, I wouldn't even dreamed of when I was, training, which doesn't seem that long ago. So I think the end results are pretty good, but it's definitely challenging. And, one of the things we talked about was the regulatory environment. And I think in general, that's a very good thing. But it does slow down the process, I think for good reasons, for safety reasons, but definitely presents some challenges too.
Well, I would think that in order to progress, innovate, you probably need a lot more skills than just the innovation, given the regulatory framework. And do you think that we're losing some innovation based on that? And is it worth it because the innovation after this regulatory process is so solid that you'd rather have some hurdles that people have to run through and skills that they have to adopt in order to get their ideas into practice?
Yeah, a really good question. And I had sort of two answers. I think the notion of one person having to have expertise in absolutely everything does create an insurmountable challenge. But I think what it has done is given the rise to multidisciplinary research. So I have extraordinary collaborations with engineers and biologists and computational people. And we've learned to work together as a team. And I think ultimately that's where the greatest good is going to come from. And I think maybe the day of the surgeon scientists working in a silo has come to an end or is coming to an end. And while an individual might not be able to do it, a team can not only do it but do it better. So I think that it's given rise to this sort of team science, which I think is really spectacular. If you look at sciences from a maturation perspective, something like physics or math are much further developed than something like medicine or biology. And when you read a particle physics paper or a math paper, all the authors are listed alphabetically. There's no first author or last author. Everybody just says what they did, and it's great. As opposed to the more archaic medical field where there's a first author and a last author, and all this stuff has implications. And it's because we're still kind of working as individuals rather than as a team. So I think we're seeing a transition to team science, and that's great, and will only have good implications.
Is there a lot of innovation happening outside of teams as well, though? I think I'm comparing this to the world of technology in the private sector, where you've got these gigantic companies and they have armies and legions of engineers that are working on all sorts of gigantic problems. But you have enormous innovation bubbling up in small companies that are 1 to 10 people, and they can make remarkable strides before they need to hire very many people. I actually was just at a conference that was highlighting artificial intelligence, and they had a guy on stage who had built a company of 10, 20 people, and he didn't raise money in a round, and he had to fire 19 of them.
Okay.
So it's just him. And then he starts to grow and he starts to build, and he winds up outsourcing 250 independent engineers to help him. And so daily he's creating products and working with all these people. And now he's adopting AI, and he's informing them all that they have about 3 to 6 months before he won't need them. And it's not that I don't even know what this company does, frankly. It's not so much that, but the amount of innovation that this one individual and the 20 employees and the 250 outsourced employees were able to, the amount of progress they were able to make without being part of a centralized structure that required teamwork and various silos of expertise all coordinating properly. It seems like the centralized version can be very restrictive to innovation of the type that you get in the field, bubbling up by individuals.
Yeah, so we're early enough or nascent enough in the evolution of team science that our teams are still really pretty small. Instead of being one lab with, maybe a principal investigator and a few people working for them, I'm talking about, five, and in big cases, maybe 10 labs working together, as opposed to
Yep.
a company that will have hundreds of people. So we're crawling before we walk. So I think the innovation is good, and I totally agree with your point that the smaller groups are going to be more innovative.
Yeah, well, it's my impression that there are legions of medical scientists working on projects, small and large, in large organizations and small organizations, and they're just working on different things. And if somebody wants to innovate in your field, for instance, then you really do need to develop more skills. You need to work with regulators over a long period of time, and anybody that has that kind of an idea has to move into that environment, or it's not likely to be successful.
Yeah, and that raises a really interesting point is, when should things transition from an academic laboratory to industry? And I think historically that happened earlier, and I think now we're seeing it happening later and later. So, for example, I'm in a what's called an exploratory confirmatory study, a final clinical study for our draft. And I have industrial partners, but I've done all the work with my laboratory with federal funding. So we've developed and translated the technology to a much greater degree than you would have historically. And I think that can be good. When I look to the future, if I wanted to make things better with this process, I think I'd like to see, at least for the more innovative products that are being developed for the more life-threatening diseases. I'd like to see the bar for getting into the clinic a lot lower, but I'd like to see the bar for staying in the clinic a lot higher. The way things are now is you sort of do all of this really rigorous work to finally get approval, and then staying in the clinic is fairly simple. And I think if we allowed academia to do the first in man studies more, um, de-risk things a lot more, it could improve the efficiency, and could be done in a more cost-effective way that would increase quality.
Some people are pessimistic about the future because our healthcare system seems to be way too expensive, and the macro outcomes, if you look at the population in large, it's easy to be pessimistic about it. Are there things that you see people complain about the healthcare system that are really, they shouldn't be complaining about? They're not really big problems, and vice versa. Are there problems that they see that are problems and are difficult to solve that you have any thoughts on?
Yeah. No, so I think American healthcare is inefficient. I think we have some of the best technology and the best training and the best doctors, but I think our systems suffer from some serious problems. And I think it comes down to two fundamental things. One is healthcare a right? And if healthcare is a right, are we measuring on an individual basis or on a societal level? So, in the US, everything is based on the individual. And it's hard to ration care when you have that. If you look at the system in England or Canada, they've made decisions as a society that there's certain things they're going to offer and certain things that they're not going to offer, and that really controls costs. But it comes at the expense of the individual. So I think that's a basic question that the country needs to answer for itself. Is the individual the unit that we're going to analyze everything on? And if it is, how do we build an efficiency? Or are we going to make, you know, decisions based on a societal level, which would require, a fundamental change in the way we view the world and the way we do things. The other major challenge is the intersection of for-profit and not-for-profit. And I think there is where probably one of the biggest rubs lies, where that causes the inefficiency and causes the rise in costs. The argument for it is that it also builds in quality, which I agree with. Um, but I think the answer there is maybe some realignment. I'd like to see alignment of stakeholders where you have healthcare systems, insurers, drug developers, and device developers on the same team, and that maybe a mission-driven corporation where the mission is improving healthcare efficiently, and then I think we could still use the for-profit, not-for-profit model, but it could be rearranged in a different way so it might work better. An example is some hospitals now are also insurers, and it works out quite well. So a case in point is during COVID, many hospitals had to stop doing elective surgeries, which is usually where a lot of the revenue comes for the hospital. Um, and so the hospitals lost money. But if the hospitals were also insurers, they made money at the same time.
Right. The insurers made all the money by not having to pay for the elective surgeries where all the profit dollars were.
But when you have hospitals that are insurers, that really works out and smooths out, these problems. So I think I think upon that, you could build drug and device companies where we could really de-risk a lot of the technologies using healthcare systems and use it by combining the healthcare systems and the insurers that would de-risk things that would drive the cost down for developing new devices and drugs quite substantially. But at the end of the day, that the benefit of that could be then that everybody's working towards the same mission to improve healthcare, and I think it would sort of fix itself.
And are you, from your vantage point, do you see that model as one that's spreading, and that others are adopting across the country? Is there a merging, a blending of those roles?
I think we're just starting to see it, and I think it's really exciting. I think that's where the future lies. I think that's where improvement will come from.
It sounds like you're pretty hopeful that our healthcare system may have its flaws, but we've got the ability to straighten it out.
I am. I'm quite optimistic.
I think so too. One of the frustrations I've always had about listening to the political arguments about the healthcare system is that nobody ever states the objective up front. So everybody has these great plans and they work just great for the problem that they don't state. And then, of course, they don't blend with the ideas that the other people have, no matter where they are, no matter what their proclivity, no matter what industry they're from. Everybody's got a different idea because nobody's really trying to get at what is the ultimate objective, which you very clearly elucidated a minute ago. Are we after individual outcomes, or are we after the overall societal output?
And is there a way to balance that? Can you have your cake and eat it too? Within certain parameters, can we keep things individualized, but at least take care of the low-hanging fruit where society's health can improve in general?
When all of your discoveries are packaged and delivered and FDA approved, what does it look like for the 1/3 of the 1% of childbirths that are born with cardiac problems for their outcome in their lives?
Yeah, I think if we were able to get FDA approval and our preclinical data holds, that we could reduce suffering and improve quality of life and improve both mortality and morbidity. The particular problem that we're working on is a thing called single ventricle disease. And these are a diverse group of structural problems with the heart that result in the formation of a single ventricle. And the operation for it is called the Fontan operation. And in that operation, you need to have a very large vascular graft that connects the inferior vena cava to the pulmonary artery. And that graft can cause problems down the road. Those problems can reduce exercise tolerance. Those problems can require additional surgeries and additional interventions. So hopefully we would be able to reduce all of those, which would be good. But ultimately, the Fontan operation is a palliative operation, not a curative operation. In other words, it's good in that it makes patients live longer, but it's bad in that it doesn't fix the underlying problem, that they only have one ventricle. And so it's an imperfect fix that I think we could improve significantly, but still incrementally. So the question is, can we use regenerative medicine in any way to cure the problem? And I think that there's some really exciting developments that aren't not in the immediate future, but I think hold promise for the next generation. The one I'm most excited about is changing the time that we intervene. So rather than waiting for the child to be born with this congenital cardiac anomaly, we can actually diagnose um, this disease before the patient's born, prenatally, using either echocardiography or MRI. And because we're able to diagnose it prenatally, we actually know a lot about how it forms, how this cardiac anomaly forms. And there's a saying, no flow, no grow. And that's how they describe the development of the heart. If you have any sort of structural defect that changes the flow of blood through the heart will develop abnormally. So some of these single ventricle anomalies arise because there are uh, narrowing of the heart valve in the fetus. And what you can do is you can actually perform a fetal operation where they open up that heart valve in the fetus, and that restoration of flow in a significant number of patients will reverse the problems with the ventricles. And so, what I envision is the application of regenerative medicine technologies in utero. And what we could do is actually replace those abnormal heart valves in the fetus. And these can all be done with catheter techniques. They're minimally invasive. You can replace a heart valve basically with a big needle. And
That
this
is just mind-blowing.
it would provide us with a curative strategy. And what we're really doing is taking what's becoming a well-established technology, but implementing it in an environment that's hardwired to regenerate. So the fetus is, just the way it grows and develops is mind-blowing. And we can leverage that to improve our ability to care for things. So that's sort of my dream for the future. I'd like to see that happen.
That's unbelievable. It's really unbelievable. So the last topic is artificial intelligence. What is the promise for all that?
Yeah. Now we use artificial intelligence and computer modeling quite a bit. In my work in particular, the computer modeling has been really, really exciting. We work with an interdisciplinary team with modelers from Yale and Stanford, in addition to our team here at Nationwide. And we've actually developed computational models that can describe and predict how the tissue forms when you implant the tissue engineered vascular grafts. And they're actually quite predictive, which is exciting. And now what we're doing is using those models to help optimize design. And what this has done is it's rather than using a very inefficient trial and error approach where you learn something and then you try and tweak your design to get it right and then you see if it works, using the computational modeling, you can do a lot of that work on the computer. And so it really starts to minimize and refine the experiments you do, which can really sort of accelerate how you can refine your product. And that's really, really valuable. And then we've been using a lot of artificial intelligence to uh, automate many of the more mundane sort of measurements we do. So I have a funny story. I had a research fellow in the laboratory, and we do a procedure called IVUS, which stands for intravascular ultrasound. And so she'd get these pictures of the inside of a blood vessel that looks sort of like a weather map. They're black and white dots. And she'd have to manually go through and outline the lumen of the blood vessel and then the outer layer of the blood vessel. And she brought this work home and was working on the couch doing this. And her husband came home, and her husband was doing a postdoctoral fellowship sponsored through NASA, developing AI for some astronomy applications. And he said, "What are you doing?" And she said, "Well, I'm segmenting these IBIS images."
What does it look like I'm doing? I'm drawing.
He goes, "That's the dumbest thing I ever saw." He goes, "We can use AI and automate this for you." So within like a couple months, they had automated the whole process. It would take about 10 minutes to manually segment each one of these pictures, and now it's done in 2 seconds. The results are better, and we literally do thousands of these. So in one night of AI, we could do the work that would have taken us a year, and so it's great.
That's great. Yeah, it just seems like an accelerant
Yeah,
to
very powerful.
exciting change. Well, Chris, it's great seeing you. Thank you so much for joining me today. This is really interesting.
Thanks for this opportunity, Bob. I really appreciate it.
Hey, if you like this clip, please hit the subscribe button. You might also want to check out some of the clips I've posted with my many other guests. My interviews all address the simple question, how screwed are we? We ask experts about the problems that make Americans so pessimistic today, but we also explore why there's never been a better time to have been born than today. Join us for perspective on today's challenges and opportunities.